Hi, class. I wish I could come up with a better greeting, but I think we're stuck with hi, class. This recording is Chapter 15, Feeding and Swallowing Disorders, and there will only be one video for this one, and we'll finish the rest in class. It's one of the shortest lectures of the semester. There's one other that's about this short as well. So feeding and swallowing. First off, a definition. Dysphagia. I think I've told you this before. Dysphagia is the term for impaired swallowing or an impairment of the ability to swallow. And this is a type of feeding disorder. And it becomes part of our responsibility as SLPs, I've said this before also, because of the overlapping oral mechanism systems. So our responsibility in working with feeding and swallowing covers three basic areas. The first is improving those oral motor functions required. So improving the strength and the coordination of oral motor function. The second is improving oral motor muscular tone. So helping to increase or improve tone and posture of the articulators for purposes of feeding and swallowing. And then the third is improving oral motor sensation, the sensitivity to taste and to movement and to texture during feeding and swallowing. So we're first going to cover pediatric feeding disorders, and I think I may get through these in this tape. I may not. We may have to cut that one off kind of in the middle, and then we'll do those related to adults. So, pediatric feeding disorders, a child's persistent failure to eat adequately for a period of approximately 1 month, which results in a significant loss of weight or failure to gain weight, is essentially the definition, for lack of a better term, of what constitutes a feeding disorder. And it usually demonstrates itself in one or more of the following ways. Either there's an unsafe or inefficient swallow, there's a growth delay in either weight and or height, there's an unusual lack of tolerance for food textures or food tastes, or very poor appetite regulation. In other words, a child who just doesn't ever seem to be hungry, or a child who seems to be hungry all the time. Of the children admitted to the hospital for failure to gain adequate weight, about half of those are due to feeding disturbances. And we're going to talk about risk factors for that in a bit. But for example, children in the neonatal intensive care unit who are medically fragile will need feeding support because of things like underdeveloped neurological or respiratory systems. So, for example, infants who are preemies or who have very low birth weight. They also, because of that, will not begin on the typical path of developing positive, pleasurable oral experiences that come along with typically developing newborns. So the physical feeding problems, even once we resolve those physical problems, it's not likely going to be the end of feeding challenges. Feeding routines, different tastes, textures, food refusal or aversion to foods are things that may follow along even after we've resolved physical feeding issues. Specifically, dysphagia occurs when an individual, now in this case either a child or an adult, exhibits an unsafe or inefficient swallow pattern that undermines their eating or drinking process. The individual will exhibit difficulty in at least one of the phases of the swallow, which we're going to review in a minute. We already talked about them previously, but we're going to review them in a minute. Just a couple more definitions. Deglutition is the fancy word for swallowing. Swallowing is a complex neuromuscular process. The substance, either the food or the drink that we're swallowing, is called the bolus. The term penetration is for when food or liquid enters the larynx, and then aspiration is for when that food or liquid passes through and beyond the larynx and into the lungs. So, review of the 4 phases of a swallow. The first is the oral preparatory phase. And this is when we are containing that substance to be swallowed by closing the lips and manipulating it into the bolus. So, in other words, chewing, even if it's a liquid, there's that manipulation of it to put it in the right place on the tongue to move it. So we're consolidating it so that we can move it. The second phase is the oral phase, and this is now moving that bolus to the rear of the oral cavity. So in order to do that, the tongue presses up against the hard palate, and there's tension in the muscles of the cheeks so that the bolus is propelled backward. Where all of this time we're maintaining normal breathing. But you remember, this is why we said talking and eating together, not a good idea. The third phase is the pharyngeal phase. Now the bolus is propelled downward through the throat to the esophagus. The bolus arrives at the anterior fascial pillars, so in the very, very back of the pharyngeal area, and the swallow reflex is triggered, and the bolus is propelled downward by sphincter action of the muscles involved. It's a critical phase because it's in this location that the substance or parts of the bolus can be misdirected to the larynx. But we have safeguards built in place. During the pharyngeal phase, the soft palate moves up to prevent the food from going into the nasal cavity. Boy, I was very nasal when I said that sound. The larynx moves forward and higher in the neck to keep it out of the line of descent of that bolus. The epiglottis folds down to cover the larynx, and both the false and the true vocal folds come together and close tightly, so breathing has to stop for that moment. If something does begin a misdirected descent, then usually a reflexive cough happens to expel that substance. Again, there's a brief halt in respiration during the pharyngeal phase, and that's called the Appendic Moment, A-P-E-N-I-C, Appendic Moment. The fourth phase is the esophageal phase. This is where the bolus now moves through the esophagus to the stomach, and that can take anywhere from 8 to 20 seconds. 20 seconds is a really long time. If we were all to stop right now and look at a stopwatch and see what 20 seconds is, you think, wow, how could it possibly take that long for something to reach my stomach? Well, it's that sphincter action of the muscles. It's how big the bolus is that you're trying to swallow. I'm sure you've all experienced the sensation of, oh my gosh, something is stuck in my throat. It's really not stuck, but it is moving slowly because of some issue. It's either too big or too bulky, or there's some other physical reason, and it will eventually move down, but it can take up to 20 seconds. With dysphagia, swallowing is inefficient, unsafe, or both. When it's inefficient, our main concern is adequate nutrition. When it's unsafe, then there's the greater risk of penetration or aspiration, both of which have resultant health concerns that we would like to avoid, things like infection, pneumonia, choking, which results in lack of oxygen to the brain. When dysphagia is present, feeding or dietary changes have to be made, and any alteration in feeding or diet comes along with its own risks. So you can see this is a really significant health concern that we get involved with. It's really important that you do understand, though, that dysphagia on its own, so a disordered swallow or disordered feeding pattern, is not a disease process on its own. It is a symptom that comes along for the ride with an underlying etiology or an underlying cause, such as, but not limited to, neurological injuries, progressive diseases like ALS or Parkinson's, head and neck cancers, or the treatment of them. In young children, it could be the result of complications of low birth weight, prematurity, or disorders like cleft palate and cerebral palsy and Down syndrome, or any of the same neurological injuries that would impact an adult. In the pediatric population, the evaluation process in the evaluation process, it's important to look at how feeding and swallowing differs from the norm. Remember that word? The norm, what we would expect from children of the same age. In other words, we're not going to look at a 1-year-old who can't chew like beef and say, wow, that's problematic. Guess what? Most 1-year-olds can't chew that. So we look for the norm. What is the typical child at each age level expected to be able to do? And where is this child we're assessing differing from that? So in pediatric assessment, we are going to come up with one of 3 things, maybe a mix of them, but is feeding or swallowing unsafe? Is it inadequate? Or is it inappropriate? So it's kind of a ranking of severity of the issues. Unsafe. We're going to start with that first one. Unsafe, the most significant. Unsafe feeding or swallowing in an infant is one who cannot negotiate the suck, swallow, breathe pattern that's required for taking in adequate nutrition. It's considered unsafe when there's any risk of aspiration into the airway. One example the book gives is the infant who, because of a cardiac or pulmonary issue, breathes too rapidly. So when they're feeding, liquid tends to pool in the oral pharyngeal cavity and can then spill over into the airway, even if a swallow isn't triggered. And it can spill over even if that swallow reflex hasn't been triggered yet. If the risk is considered great enough in a situation like that, then a feeding tube will be required to provide adequate nutrition for that child while they are receiving some other kind of therapeutic intervention. So we listed some causes or risk factors earlier, but just to highlight a couple for pediatrics especially, children with cerebral palsy, if you recall, have a disorder that affects volitional muscle control, so the purposeful muscle control. Either their muscles are hypotonic or hypertonic. This condition affects the ability to control the oral muscles as well, the oral pharyngeal muscles. 33% of kids with cerebral palsy present during their first year of life with failure to thrive. And that's because of nutritional issues related to feeding or swallowing. So a speech-language pathologist is almost always going to be on the team that's providing services for kids with cerebral palsy. Children with cleft palate have difficulty achieving an oral seal, so getting that good lip closure or having the dentition or the jaw structure needed to get that oral seal. So food or drink may enter the nasal cavity through the cleft, remember, which is not typically repaired until sometime around a year or even later. So those kids are also going to need SLPs on their intervention teams. If we get to inadequate, now we did unsafe, inadequate feeding or swallowing. These are little people who are unable to achieve the nutrition that's needed for typical growth and development. And that usually happens for one of 4 reasons. Sometimes there's some overlap. The first is inefficiency. The feeding process for them is just not productive. They fatigue easily or become breathless. They show a disinterest or lack of persistence. And this is like, now we're talking about infants, so still babes in arm. We're either breastfeeding or bottle feeding, and they fall asleep, or they're just not interested in this. They can't get adequate enough airflow, so they become breathless. So this is a very inefficient process for them. The second reason is over-selectivity. Their eating patterns are restrictive in either taste or type or texture or volume. This is not simple pickiness. This is not the toddler who, will only eat chicken nuggets or who won't eat anything soft. This is an extreme case, an extreme stress on a family, as well as a diet that's really inadequate for the child's growth and development because of an inadequate intake of nutrients and calories. The third is refusal, and this is obviously very serious. This is the child who's refusing to eat. And there are about three most common reasons for that. The first is there may be a physical or medical issue that's unresolved that needs to be discovered and resolved. So, in other words, eating is causing this infant or toddler extreme discomfort, and their appetite and hunger are disrupted by that discomfort. The second is gastrointestinal distress, such as reflux. And we do hear about this a lot with infants. They have reflux that's causing some pain or that's causing them to lose food because they're spitting food back up. And so then they begin to refuse food. The third is called a conditioned dysphagia. And this is usually caused, not usually, this is always caused by some trauma associated with eating, such as having choked severely or some ingestion of poison and the pain that went along with that, some severe allergic reaction to food that now has this infant, toddler, preschool child afraid to eat, and so they are refusing to eat. So I can tell you one story about this. By the way, I should have started this chapter with the disclaimer that this is not by any stretch my area of expertise. When I was in graduate school, we talked about this very little, and I have never worked in a position where I'm doing feeding and swallowing. So I'm telling you this from the point of understanding all of this vocabulary and having a few examples to give you, but it's certainly not my area of expertise. But I'll give you this example for conditioned dysphagia. One of my nephews was born with failed kidneys. He was like in the medical dictionary under child disorders and child surgeries. He's like, there's his picture practically because he was one of the first children in the United States that they identified the kidney failure in utero, and he was born with failed kidneys. So he has been on dialysis the vast majority of his life, and he is in his, I want to say he's probably 30 this year. So obviously there's been some positive. But when he was a preschooler, a toddler, he had such problems with food because of failed kidneys. You have to regulate intake of potassium so significantly that there was so much he couldn't eat, but he didn't have any control over any of this, and he was in and out of the hospital for various surgeries or I know other procedures, that he just decided to take control of one thing in his life, and that was eating. And so he basically just stopped. He refused to eat. And he was tube fed. First, the mom and dad could do some of it at home with the nasogastric tube, but eventually he had to have the permanent feeding tube implanted. And I remember him sitting in a high chair at my house one day. Was a birthday party for one of my boys, and we put a cupcake on his tray just like everybody else's. And my sister, not his mother, other side of the family, looked at, she goes, "What do you mean he doesn't eat?" She goes, "Look, that cupcake is gone." And I said, "Look at the floor." And he'd had a great time shredding it all up, and he may have tasted it here and there, but it was all on the floor. He just refused to eat, and that was a case of conditioned dysphagia that took a lot of effort, with a lot of assistance from speech therapists and occupational therapists and psychologists to get him back to the point where he could get an adequate intake of food without feeding tubes. So the fourth reason that we are doing pediatric treatment is feeding delays. And this is because of slow development of the major milestones due to actual developmental delays or illness or trauma. So these are maybe our kids that have intellectual disability, or in the cases like my nephew, who've been hospitalized so much that it has impacted their achievement of normal developmental milestones. Well, one thing that you need to know is that the major milestone achievements, so sitting up on your own, rolling over, crawling, then to walking, those also correspond with increased nutritional needs in a child. The minute a child learns to crawl, they need a bigger caloric intake because they're now expending different energy. Once they can walk, they need a higher caloric intake. So when a child is delayed in reaching those milestones, their nutritional needs also become at least undermet, because we also need those increased nutritional needs for cognitive development. And so we have to look at those milestone achievement as tied into nutritional needs. So, some causes and risk factors. What are some of the major issues that result in? I'm sorry, I'm going to log back into my computer. I know that doesn't affect you guys, but I can't see the screen. There I am. Okay, some causes and risk factors that result in major issues in pediatric feeding and swallowing. Well, the first one, probably the most common, is low birth weight. So when kids have low birth weight, they often fail to achieve adequate nutrition on their own. That low birth weight triggers all kinds of other problems along with it. And in our case, it's that achievement of adequate nutrition. The next is prematurity. And when children, by the way, when kids are born with low birth weight, that can be an on-time delivery. Low birth weight doesn't just happen because of prematurity; it can happen because of other issues. So prematurity is considered on its own, and it brings its own set of issues. When a child is premature, they have an immaturely developed neurological system, digestive system, respiratory system. All of that impacts their ability to be fed and to be successful in acquiring the needed nutrition. The third major cause and risk factor is prenatal drug exposure and fetal alcohol syndrome. Both of those things can result in either prematurity or low birth weight. Maternal drug use, even after the time of birth, can result in poor attachments, which are often developed around the routines of feeding. If you remember, we talked about attachments a little bit, I think, way back in the chapter on development, healthy attachments. Most of those are made with mom, especially, but even with dad in some cases, around the routines of feeding. So we know parental, let's not just blame it all on moms, parental drug use impacts how kids develop those healthy attachments around feeding. And then diet restrictions. I explained, like with my nephew, diet restrictions in a child for whatever reason. Usually it's for a medical reason, but may result in feeding issues and a resistance to feeding. So, for example, a child who maybe has severe allergies and so has significant fear around eating may have significant diet restrictions simply because of that fear. So that was all inadequate. We talked about unsafe and then inadequate. And then we get to inappropriate feeding and swallowing issues. Behavioral issues is what we're talking about here mostly. So these are undesirable and disruptive behaviors at meal times. Now, this is beyond the typical, I'm going to have a tantrum because it's dinner time and you're giving me peas and I wanted carrots, or, just the typical child behavior. This is serious and stressful struggles between caregivers and child. So it can result in eating too slowly or eating too quickly or too selectively. The causes and risk factors here, honestly, often involve parent behaviors. So we're going to talk about parent behaviors that can result in this. Things like the environment being, or the parent being very overactive or very overstimulated during meal times. So the parent who never sits down at the table and is rushing around all over the place and just too busy to sit down and have a calm meal time with a child. So everything around the child is overstimulated. Being underactive, passive, and unengaged, also a problem. Putting a meal down in front of a child and walking away, and the child's left alone. Not a good environment. Being rigid or directive or demanding. So the parent who, the absolute clean plate club, but taken to an extreme level. You will chew every bite 20 times. I grew up with kids whose parents were like that. They'd count as the child was chewing. We have to be healthy and not choke. So I'm going to count and make sure you're chewing every bite 20 times. Being overly directive about how the child is eating. Huge problem if we want appropriate meal times. being chaotic or disorganized or frenzied. So this kind of goes along with that overactive, overstimulated. We've got the television playing off on one side of the room, and maybe someone else is sitting at the table, two people having a loud conversation, and everyone's ignoring the child that's needing to be getting adequate nutrition. Or someone's having a fight in the background. And then the next one is being over concerned and anxious and fearful. So, keeping a child on pureed foods when you should be introducing little crunchy foods because you are afraid of what's going to happen. So you can see parents have a huge part to play. And in this case of dealing with pediatrics, we really become a counselor far beyond just working on the physical issues. We have to be very involved in what mealtime looks like for these kids. Early intervention is hugely important for obvious reasons. But let me just highlight for you. Research in Montreal found that the mean age of onset for failure to thrive is about 9 months of age. But the mean age of referral to a pediatrician from a pediatrician to a feeding clinic is 19 months of age. That's a 10-month gap. Obviously, this is referring to children who are presenting a disability that isn't indicating a life-threatening situation. But if we don't resolve those inefficient and less severe feeding issues, these kids could have eating disorders that extend through their lifetime. So we need to work on all of those things with kids as well. We get involved as an SLP after the referral to a feeding clinic. We complete a comprehensive assessment that includes a history, physical feeding and swallowing evaluation, and observation of mealtime interactions. And I'm going to stop our video right here, and we'll pick it up right there talking about that assessment when we meet in class, and then we'll move on and cover the adult disorders as well.